We had all the information up front, and we were able to make an informed decision.
We established a new principle of allogeneic transplants for patients with multiple myeloma, which we call T-cell depleted bone marrow transplant. That, in my initial clinical trials, has shown that we could reduce the acute graft versus host disease and in fact chronic graft versus host disease to very low levels. We then integrated as a next step adoptive cellular therapy approaches. We found out that patients who got donor lymphocyte infusions developed antigen-specific T-cell responses targeting a marker on the myeloma cells that is called a Wilms tumor antigen 1, or in brief WT1. The knowledge that we obtained from the initial clinical trial led then to a subsequent trial where we are developing WT1-specific T-cells that we can then infuse to patients after the allogeneic transplant. When this patient presented to me for this approach, the clinical trial was not approved yet. It was in the making, so to speak. But knowing that it was in the making, the FDA allowed me to treat this patient as if she were on the clinical trial on an SPU or single patient use. I think this clinical trial and this approach may be a real game changer. So this is the clinical trial design. Once we established the appropriate donor for the transplantation, we admit the patient for transplantation to the hospital, and we'll start out with chemotherapy, which is shown here. The uniqueness of this clinical trial is that we are now able to administer Wilms tumor antigen-specific T-cells, or in short, WT1-specific T-cells following the transplantation. The advantage of these T-cells is that they are highly specific to recognize multiple myeloma cells. The donor dendritic cells are pulsed with WT1-specific peptides, and they are highly recognized by the T-cells that were generated over 6 to 8 weeks in culture, but they don't have any alloreactivity left, and therefore we are very little concerned that these cells induce graft versus host disease. This is important for this clinical trial because if you administer these cells 6 weeks following transplant, you have otherwise a very high potential to induce graft versus host disease. And what happened in this particular patient is what you can see here after the transplantation and the administration of the WT1-specific T-cells. There was a rapid increment of CD8 T lymphocytes and CD4 lymphocytes. But you can also see that a large fraction of these cells were producing intracellular interferon gamma against peptides that are derived from the WT1. Therefore, what we know with this result is that these cells are specifically recognizing the myeloma cells. What really is interesting, and it was totally unknown to us before we did this treatment for this patient, when the patient came out from transplant, she still had significant amount of disease as measured here by an M-spike. But after we gave the initial round of T-cells, the disease markers came down. In fact, it came down, but it was not negative. At that point, I asked the FDA to give me permission to treat the patient with another 3 doses of these WT1-specific T-cells, which we did, and subsequently the patient entered a complete remission, which has been lasting now for about 2 years in total.
I'm just so glad to be here. I couldn't have done it without the dedication, the compassion from the doctors, the nurses, the whole team.
Having this patient and her husband walk into my clinic after very strong chemotherapy, very weakened, and asking me, is there anything else we can do? And see her now, 2 years later, in good health and in complete remission is clearly an extraordinary experience.